Hi everyone, welcome to Cross Theme Seminar. We have 3 presenters. Thank you very much each for coming to present. Format is around 12 minutes, although we might run over, like you say, Hannah-Louise, and then 5 minutes or so for questions. Do you want me to share the screen already? Your slide, sorry. No, that's the wrong one. Start out.
Wonderful, thank you. Oh, it's hidden. Where is that? Yes, there we go. Thanks so much, everyone. Great to have this opportunity. I'm Hannah-Louise Clark. I'm here from Economic and Social History, and I'm going to talk about a very small portion of my research on historical discrimination in health professions, looking at the case of Algeria under French colonial rule. But I want to connect this research with a very contemporary issue, a problem that's happening over the border in NHS England, and that is to do with how they are dealing with a crisis in recruiting, training, and retaining doctors. So connecting Algeria to this contemporary issue. And in the NHS England workforce plan dated June 2023, they talk about training the workforce more efficiently and getting people into medicine differently. And one of the things that means is employing non-physician practitioners. So I've seen on Twitter, or the app formerly known as Twitter, there's a lot of concern and also questioning about what might this look like. And so I'm going to talk to you about non-physician practitioners in Algeria. And there's a good reason for looking at a colonial example, because medical assistants or physicians associates, they come out of military medicine, but then there's a massive expansion at the end of the 19th century and the early 20th century, all in colonial contexts. So I'm going to share a bit of that history from Algeria, and by the end, I hope I'll have brought it back to thinking about these contemporary questions. Because I've undertaken a study of the interactions between medical assistants in Algeria and the French colonial state from the beginning of the 20th century through to Algerian independence and after. And I'd be happy to talk a little bit, more about the details. This is going to be a scandalously short overview. So I'm going to give a bit of historical background on Algeria, some theoretical background, talk very quickly about methods, and then some key findings. And I hope you'll take me up on, hope you'll ask lots of questions afterwards. And I just want to say that if I convince you of anything by the end of this presentation, it's that I hope that historical cases are worth considering, even if they are related to very different political, cultural, geographical contexts than the ones you're working with, because they can help us ask better questions if we're thinking about determinants of health and health inequalities. And in this particular case, they can also alert us to consequences that policymakers or organizational leaders might not have considered, might not be able to foresee or control. So a little bit of background. I don't know how familiar you are with the North African country of Algeria. What I want you to sort of get in this historical background is that Algeria, from the period 1830 through to 1962, is, for most of that period, it's considered part of France, as this map proclaims. So there are some historians would compare it to apartheid South Africa. It has a lot in common with Ireland's relationship to Britain under colonial rule, because it's considered part of France. And what this means over the course of the 19th century, as the French invaded in 1830 and gradually over time replaced local political authorities, took control of the legal and administrative apparatus, took control of land, settled Europeans on land, and forced autochthonous Algerian Muslims and Jews to resettle elsewhere, leading to gradual domination over the autochthonous population, which was considered as native. And that word, which is very pejorative, used pejoratively and considered a very pejorative word today, native, reflects the fact that over the course of the 19th century, France awards citizenship to different groups of people. So not just people who are born in France, but also Algerian Jews are mostly given citizenship from 1870, and also different Europeans who come from Spain, Malta, Sicily, Germany, people seeking opportunities, people leaving Europe, coming to Algeria are given citizenship, but Muslim Algerians are not. So until 1958, the majority of Algerians who had Muslim heritage were excluded from citizenship on the basis of their religious background, irrespective of how pious they were, whether they practiced Islam or not, they were categorized as native. And this has a lot of implications. They don't have the right to vote, for example. They are placed under a very draconian criminal code, and it also restricted opportunities like education and different careers. And this category is a state-organized category of native, is a racialized category, because you could convert to Catholicism and you would still be considered as a native in legal terms. So it's not about religion. So I should say that Muslim men are eligible to apply for French citizenship when they reach the legal age of majority, but it's a very difficult process and very few people were prepared to take that step. So at the beginning of the 20th century, copying imperial policy fad elsewhere, it was decided to create so-called native medical assistants, non-physician practitioners, to deliver healthcare in the more rural zones away from European settlements. And this career opportunity was offered to young Algerian men only who had native status. And the selection criteria included a maximum age limit, so they were only 19. So they were legally minors, so they couldn't have become French citizens even if they wanted to. So in my study, I'm looking really at how race and religious discrimination, but also gender and class, shaped this organization they worked in, shaped their recruitment, their training, how they're managed, how they're paid. There's a religion pay gap that they experience. And also how it shaped how they delivered healthcare in rural areas. And I probably shouldn't dwell too much on the theoretical background, but just to say there is a lot of literature. There are a lot of site-specific historical studies about medical systems under empire, ranging from India to Indonesia. But often this research looks at medical assistants, like the ones I'm talking about, as cultural brokers, intermediaries between a dominant colonial society and a colonized population. And that's certainly a very good lens for looking at them, but it overlooks the fact that doctors and other healthcare professionals work in organizations, and organizations have culture, and that culture can reproduce and reinforce inequality. So that's what I'm very interested in. And I'll also mention historical studies of racial medicine. Algeria has been seen as a key case for thinking about race and medicine. You might think of Frantz Fanon, perhaps, if you're familiar with some of the literature on kind of post-colonial approaches to medicine. Well, the thing about many studies of racial medicine is that they look at an academic textual corpus, which is very good at uncovering prejudices and discourses about race, particularly from the pens of European writers, but it's less good at telling us how those scale up and how they're put into practice on the ground. And again, looking at an organization, looking at medical assistants and how they work in organizations is a very helpful way of seeing how racial ideologies are applied. And the last, I'll skip over paperwork because who wants to talk about that? But also literature on the sociology of inequalities and racialized organizations. So a lot of the literature on how organizations are race and gendered. From the side of racial inequalities is tended to look at North American examples. They're looking at white supremacy and anti-Black racism in organizations. And as you can see from the photographs of these men, these are some medical assistants in Algeria, they're white adjacent, and what marks them out is not skin tone, but very subtle differences in headgear and clothing. I'm happy to talk about that more. So there's this racialized category of native, but it's also about religious difference and class and gender, as I said. So this is what two archives look like that I worked in. My work is based on qualitative analysis of a vast quantity of handwritten typed documents in Arabic, Algerian Arabic, and French that I collected in different sites. And what I'll say, a couple of things I'll say about this: to do research in Algeria, you need to have the resources to be able to travel to different sites, because the state archives and archives for institutions like hospitals were fragmented during and after the colonial period. And Algerians considered this as a theft of their archives, which are relocated to France after the Algerian War. So that increases the complexity and the time needed to do the study. Also, I'll mention, just sort of, archivists don't have a lot of money. Mostly they just try and stop things from getting destroyed. But when they have resources, they want to create finding aids, and they've been, those finding aids are targeted towards security issues, politics, not health. So it's actually quite difficult sometimes to do research on health, because you have to cast a very, very wide net, because you're not going to find finding aids that easily lead you to items you want to do research with. And again, happy to talk more about that aspect if you're curious later. So what are some of my key findings? So I'm talking about a two-tier system for recruiting, managing, and deploying medical assistants in Algeria. So clearly this isn't the same as NHS England in many respects. However, one of the should be obvious really, that recruitment, if you've got this two-tier system, recruitment of the subordinate category within the organization, in this case, a non-physician practitioner, MPP, doubles down on existing categorical inequalities in society. So, I mean, the obvious flag is that these were so-called native medical assistants, but also class and geography were very important. The issue was not that these were not intelligent, smart people. The issue was they didn't have access to the kind of education that led to the certificates, the school leaving certificates, the kinds of courses that were required for entry to medical school. And that was because Algerians paid taxes, but European settlers were unwilling to spend money on schools for them. And where there were schools for Algerians, they studied a special native curriculum that channeled them towards careers in agriculture, so they could be labor for European farmers. So what this means is this opportunity for Muslims to access careers in medicine also reinforces existing educational inequalities. And you might ask, how might that apply in this situation, where some people can access a medical degree and become a doctor, but other people are sent in a different direction? And is that because of weaknesses and inequalities in the education system, which obviously is affected by class, but also geography? So people from very rural zones tended to take this opportunity, whereas people from wealthier families in urban settings had access to private education and were able to get into medical school. I suppose in the time I'm remaining, I'll just have to bury some highlights. So the MPP students and graduates faced organizational prejudice. So French medicine was an extremely hierarchical profession, and that mapped onto racial hierarchies also. So these students and graduates, who in many cases were outstandingly talented and went on to have really leading roles in the healthcare system after independence, were treated as less than or less able. And they also were unable to progress. So that's the question. If people become these physicians associates, do they have an option of converting to being a full doctor? And how would you manage that? And would that opportunity be something they'd have to pay for themselves? Or would you offer that as a progression? Also, major conflicts arose between doctors and MPPs. Sometimes there were very close working relationships, but where problems arose, they were often organizational problems rather than being about personal differences. And every time doctors complain about medical auxiliaries, they decide to redesign their curriculum, because they think if only the way we teach the curriculum, and if we just fix the curriculum, all these problems will go away. And they just don't, they persist, because the MPPs are subordinate to the doctor, but they're making decisions, but then the doctor's responsible for them. I mean, now we call these problems in clinical governance. But then also there was the pay scale issue. If you've got an MPP who's been in the job for, say, 3 decades, but they're now paid more than an entry-level doctor, what kinds of tensions does that lead to in your workforce? So I'll just leave it there, because I know we have to move on. But I'll just close by saying thank you for your attention. Thank you for any questions you have. And economic and social history has quite a few people who work on health and medicine, including few colleagues, Ben Hunter, Vanessa Cook, Kristin Hay, myself, Angus Ferguson, Rose Elliott, and others. We all love nerding out about history. So if there's any aspect of your research where you think, I wonder what a longitudinal, longer horizon would look like, even if it is a case like Algeria, which might seem very far from your own research, come and talk to us. We're very friendly. Thank you.
Very much. Is there any questions? Anyone online? Michael, got any questions?
We don't have any questions so far online, no. Feel free to put something in the chat box if you do.
Yeah, maybe Jonathan.
Yeah, that was excellent, really, really interesting and different, which is that. Yeah, I was gonna talked at the start about the kind of England situation now. So I just wondered how you're looking at that in terms of the kind of perspectives that you learned from your research and how you're now seeing the kind of the policy progression down there and similarities.
Oh, that's interesting. So I've mostly learned about how this is unfolding from the position of physicians and consultants who are very concerned about what it might mean, and like, are there examples of how it's happened elsewhere? And I think, so in terms of this was like a really popular, it was a fad. So it's like, oh, they do it here. The British do it in India. The Dutch do it in Indonesia. So we're going to apply this here without really thinking through how it interacts with social context. For example, if you want people to access your healthcare services, the last people you want to involve is young Muslim men. You would go to older women. So they overlook social context because they say this is an idea, we'll pick it up and we'll use this category here. So in terms of what kind of lesson, I mean, thinking about the context in which these people are going to be deployed, and then thinking about the organization they work in, as opposed to just here's a transactional relationship between a patient and this person who's going to take their blood pressure, whatever it is, but also how is the organization going to cope with these new professionals? And when people look to examples, I'll just close by saying when they look to examples, they often look to physicians associates in the US, for example. And physicians associates can be found in all sorts of places. They were introduced in the US in the 1960s, and the people who advocated for them explicitly used colonial models as examples. So it's not that alien to say, well, let's look at colonial states, because in the 60s in the US, they were doing that too. And they foresaw some of the problems that arose in the colonial situation would also arise in the US context around, say, hierarchies and kind of problems of around governance and like who's responsible in different settings. So kind of indirect answer to.
One more question at the back.
Thanks, that was fascinating. Apologies that I missed the very start, so I presume you were talking about the physician assistant in England, which actually is blown up on Twitter big time in the last few days. My question was slightly related, but obviously the other thing that you see in many countries is a drawing in of international medical and modern health data. And many of the issues that then start to develop in terms of how people are treated and viewed, the kind of career progression pathways that I think is learning then from your work in terms of thinking about that or how we apply that energies and that.
That's a great question. Yes, I think there are. So what's the period I'm looking at, end of the 19th century, early 20th century, is when professional categories go global. So the idea of like a state accredited doctor, as opposed to other kinds of healers, healing that happens in your home or healing where you go to, someone who's going to perform a service that isn't regulated by the state. So these categories and kind of qualifications are going global. And as they go global, they're being racialized. So not only in Algeria, there are tracks for doctors, and then there are tracks for what are usually called native doctors or native medical assistants. So as this category goes global, it's racialized. Now, if you look at what happens after Algerian independence, what happens to these kinds of categories? So Algeria retains them because they're very useful. They ramp them up, in fact. The racial element is gone. And it's just young people who do this for a couple of couple of years and then go on to other careers. So it's seen as a temporary state. But then what happens is a lot of Algerian medical professionals want to go to France, and France wants them for the healthcare profession. It wants them because they have similar issues we have around staffing, but they're employed on lesser contracts and they're paid less. They face discrimination. So they have, there are some Algerian doctors who were at one point French, and then at decolonization, the French citizenship, which had been offered in 1958, was then taken away. And they trained in institutions that were designed and built by the French. And so their qualifications are very legible in one sense, but they're also able to be employed on these lesser contracts and receive less pay. So I think in that sense, it does, thinking about the legacies that run through from the colonial past to the present, thinking about how some groups of people, due to categories like ethnic origin, or in the case I'm looking at, it's kind of this religious ethnic category, that those map onto organizational inequalities where, you know, it's the hiring practices. There's a system for hiring people from Algeria. There's also the question of whether people's qualifications are recognized. So, you know, whether Algerians have to undergo extra expensive testing to attest to their ability to teach, even though they're coming out of a system that was originally French. And that also, so you can imagine, leads to costs on individuals and a lot of frustration. So I do think, and you know, in the British case, you could look to say Iraq. So Iraqi doctors were really crucial for helping to set up the NHS as part of a workforce, and people who would go to places where other doctors weren't available, willing to go. And they had trained in a British medical school, yet also underwent different kinds of discrimination or lesser treatment because of their origins. And of course, up to the present, you know, the situation of doctors and the medical infrastructure in Iraq is, as we know, in a grievous state. So thank you. I'm sorry.
I didn't know that. Thank you very much, but we should move on and welcome Dimitar, who's going to be our second presenter. Thank you.
Good afternoon, everyone. My name is Dimitar, and I teach at the MSc Global Mental Health Program. And I'm briefly going to present a learning and teaching development project that I led together with my colleagues in the back, Julie and Laura. So the goal of this project was to integrate employability or strengthen the employability in our core online learning in the MSc Global Mental Health Program. And I'll run through our good practice guide that we've developed here in order to just present our methodology and our findings and some implications that we think about across programs. So why embed employability in the core online curriculum? So extracurricular activities that foster career development and employability are certainly essential, very valuable, but there are certain limitations, particularly that students are more likely to engage in activities which are not perceived as increasing their study burden. So we believe the students are more likely to also engage with online learning materials when they perceive them as directly valuable to developing specific career skills, which is especially important for digital learning, which has traditionally struggled with sustaining student engagement. And we also thought about our online distance learning students, who represent a big proportion of our total cohort, who are not able to attend on-campus seminars or live career events here at the university. So we wanted to cater to their needs in terms of career development and progression. And again, embed that as part of the online learning so that we don't increase their overall study burden. And online learning has a very important role in our programs because our online learning materials are available to both our online distance learning students, but also to our on-campus students in a blended learning and flipped classroom approach. So it was very important for us that those learning materials are perceived as relevant to career growth to our students. And also this approach is reflective of the NVLS education strategies focused on embedding employability into the curriculum. And there are indeed some good practice guides on how to do that in face-to-face teaching. There are very few guidelines I've come across that tackle with how to do this in online learning. And this is the problem that we sought to target. And very briefly about global mental health as a field. It is a relatively new field of study that is rapidly evolving. And similar to other disciplines, more established disciplines such as geography, psychology, and many others, it does not have a direct link from education to employment. And global mental health roles are scattered across many different sectors, organization types, countries, professional groups. And this creates really a challenge to develop curricula that cater to those various career pathways that our global mental health graduate will take. So in order to begin to embed employability more into the curriculum, we first wanted to identify what to embed. That's why we embarked on a job market analysis in order to understand what competencies employers today value the most, and really use this knowledge to develop a competency framework for global mental health that we then use to guide our curricular enhancements. And there are various ways to develop competency frameworks, the most common being subject expert consultations or document curriculum reviews, Delphi approaches, and others. But I argue that a job market analysis is one of the most direct, up-to-date and objective approaches to gather knowledge about in-demand competencies that employers prioritize, particularly today in a post-COVID world, in an increasingly digitalized world. And also, job market analysis can help address this very common problem that's been reported in the literature, and that is the discrepancy between graduates' expectations and preparedness and employers' expectations. So we're looking at how can we bridge this gap that's been observed in some other disciplines. So we went about and analyzed 70 job advertisements, recent job advertisements relevant to global mental health. And we actually categorize them according to the different job families. And you can see we have those 8 job families, which are still very broad, but they represent really the diversity of career options for global mental health graduates. And also, as you can imagine, it presents a really challenge to develop one cohesive framework that captures all of those pathways and careers such as advocacy, capacity development, clinical work, policy, research, program implementation and development, teaching, and other types of service delivery. So we searched for those 70 jobs, and this culminated in the development of a new bespoke competency framework that is specific to global mental health. And I can spend quite a bit of time talking about the framework, but I'm very briefly going to touch upon certain aspects and what was surprising for us when reviewing those job ads. This framework is organized very briefly in 4 quadrants. Subject, which relates to subject domains that were mentioned in the advertisements. Self, which refers to personal attributes, stable personal attributes such as intellectual abilities, which are pretty standard in jobs. But we're also surprised as how often employers mention values in their ads and require that candidates articulate an evidence and align their values with organizational values. And also what was quite surprising was the focus on this, what we've called here personal resources. Those are the non-technical, non-cognitive skills, which actually I think are very often neglected in competency frameworks across many disciplines. Examples include resilience, grit. These are all words mentioned by employers. Curiosity, ambition, drive, courage, entrepreneurial mindset. And this really prompted really interesting conversations within our program about how are we teaching those attributes, and how can we evaluate them? How can we assess them? Are they measurable? And there are also other parts of the framework that some are sort of standard and shared across other disciplines, but others were particularly novel to us in terms of how often they were mentioned. For example, knowledge dissemination and exchange, communication skills, advanced communication skills such as consensus building, intercultural communication and exchange, and others as well. So there are some really interesting insights from the framework that we wanted to harness and see how can we embed those as much as possible in the curriculum. So what we did was, and really this framework we hope will have a number of benefits, such as help current students with their career planning, job applications, and increasing career self-awareness and reflection on their progress, but also prospective students who know what to anticipate when they enroll in the program, and help employers to gain a better understanding of what skills, the range of skills our graduates will possess, and also educators who can also design appropriate programs and short courses and other forms of opportunities for career development to trainees globally. And this is an interesting question I'd like to pose. Maybe we can talk about it after. Is about the competency frameworks in your own disciplines, and to what extent do you think they are up to date and they reflect the contemporary job market, and how were they developed? Who was involved in their development as well, and how, and to what extent do we use competency frameworks directly in teaching? Just very briefly, we compared the framework that we developed with the university's graduate attributes, and it was quite reassuring that there was some overlap, although there was some outstanding insights that our discipline-specific framework contributed over and above those generic graduates. But there's also the concern that graduate attributes are quite high level, and students might not perceive them as relevant to their careers as a discipline-specific competency frameworks. Okay, so what did we do with this framework? Apart from it being helpful and it's on its own right, as I just mentioned, we looked into developing a range of enhancements in our online curricula. Specifically, we introduced several rubrics, such as what we call employability insights. This refers to an approach whereby, which very much reflects the extracted employability approach, which means that rather than adding new content to the curriculum, therefore increasing student burden, we're actually extracting or surfacing what is already being taught and linking those more explicitly with specific professional skills. So pairing core subject content with professional skills. And we've done that in a range of ways, some very direct ways. For example, we've actually used job excerpts from job advertisements embedded in the core learning to provoke students to think about the skills they're developing. And in some cases, not as the link between subject learning and transferable skills is not as straightforward. For example, we have content on traditional health practitioners in low and middle income countries, such as healers and herbalists, and their role in service delivery. But we also now encourage students to think about what it means for a capacity building worker who works in those settings to try and build consensus between such different stakeholder groups, such as traditional healers, medical practitioners, policymakers. What are the communication skills and collaboration skills that are required to work with such different stakeholders? So we've included different excerpts from ads, and I'll give you a couple of examples here. So, for example, let's pick this one. So I mentioned about those non-cognitive, non-technical competencies that were mentioned, such as drive, grit, and resilience. And we included this blurb right in the middle of a core content about certain professional challenges in global mental health. And then we're now asking students to reflect about the personal attributes such as drive, ambition, resilience, and perseverance that are important for an effective practitioner to thrive amidst those challenges. And we also, we mentioned, for instance, a job advert for a senior policy advisor at this organization specified that the candidate must display grit, courage, resilience, humility, and integrity, and they demonstrate achievement, drive, ambition, optimism. And just as we're now asking students to reflect about those challenges and the importance of those attributes in meeting those and thriving amidst such contested spaces that global mental health professionals occupy. We also included a little bit of new content, but not too much, but we focus on a new rubric called Ideas into Action, where we're trying to integrate very practical exercises and content. For example, we build new content about how to start an NGO, how to write a policy brief, how to organize stakeholder dialogue. So all those things were mentioned in the ads, and we thought there were some gaps in our provision, and we tried to address them. We also strengthened this idea about employability as adaptability, and we included a rubric called Futures Thinking, where we're asking students to think about the future of global mental health and emerging challenges and how professionals and communities can be better prepared, such as AI and COVID-19 and climate crisis. And this really embodies this idea of adaptability, which was yet another attribute that was commonly mentioned in the advertisements. And finally, we strengthened students' reflective practice and encouraged them to think about their core skills, core values, and think about how they can evidence those and develop those in the program, and how they can demonstrate those to employers. We embedded that in just various variations in the program. And this is just the exemplary mapping of all those innovations across our core learning. And just at the end of the good practice guide, there is a range of prompts and tips that we've gathered from our experience in this project, particularly about strengthening employability in the curriculum. And I welcome any questions.
So, any questions? Anyone here? Open the curriculum online. For any questions? Oh, we have one here from Peter.
Thanks. That was, excuse me, sorry, really interesting. Two things struck me. One was as you kind of pointed out, the massive breadth and potential career pathways, sectors, and options, and then also the massive range of competencies that
Yes.
in your framework. And I was curious, to what extent was the range in your framework reflective of? Is there a massive range in these things coming up all over things, or is it that there are some specific sectors that put an emphasis on particular skills and they're trying to appeal to all markets?
I mean, there was a great deal of shared competencies. So, for example, what was quite interesting to us was the ubiquity of research skills. So, research skills were required also in non-research roles as well. And there's quite good emerging evidence particularly from low and middle income countries, that strengthening professionals, for example, doctors, physicians, capacity building workers, research skills actually has spillover effects in terms of their confidence and competencies in other aspects of their work. So that was particularly interesting. And also in terms of the policy roles, we saw a great emphasis on negotiation skills, the ability to produce specific dissemination materials such as policy briefs, also organize stakeholder dialogues. Influencing skills was a term that I thought was quite interesting that one ad mentions. So the ability to influence and negotiate with others. But of course, there are other skills that were shared across really quintessential global mental health attributes such as cross-cultural collaboration and exchange, cultural humility. And compared to other frameworks that exist, particularly for example, for psychiatrists or researchers, again, most of those other frameworks tend to only include knowledge domains. And you see communication skills and you see cultural humility, but you see very little about those other what we call meta-level complex competencies such as resilience, negotiation skills, adaptability, perseverance, creativity was also mentioned a lot in the ads, which was really interesting.
Anyone else? Ask a question.
Yeah, sure. Yeah.
I was just interested in how you did your searches and decided that this was a job that was for mental health.
Yeah, we were very inclusive so obviously we have some data, anecdotal data from our graduates and we actually looked at LinkedIn a lot to see what roles our graduates tended to embark on. So we make sure that those are represented. So, but we had a very broad definition of global mental health. So, for example, we included some traditional psychology roles, such as a trainee clinical psychologist and psychosocial support workers. And we didn't restrict ourselves to global South countries. We included now a global scope, of course, within the small sample of 70 jobs. So we're trying to be as inclusive as possible in order to capture a broader set of competencies.
Very much. And I think we should move on to our final speaker. Where's your presentation? It's on the desktop. It's on the desktop. You do it. Yes. You have to share it.
Yeah. Hello, everyone. Yeah, nice to meet you all. If I haven't met you already, I'm Jonathan Stokes. I work in the MRC unit on the 4th floor now. So I joined Glasgow a year ago, pretty much today. So September last year. And yeah, so I might not have met a lot of you yet, but I was formerly at Manchester University where I started this work. But because it applies, I think, well, it applies to future work because we're talking about kind of research priorities going forward. And I think it applies a lot to kind of across the SHW themes. I thought I'd give it a presentation here as well. So yeah, this work is on a primary care research agenda on multiple long-term conditions, which I know a lot of you will be involved in some way or another in the school. And it's results from a Delphi study primarily. So background, I'm sure a lot of you will be aware that multiple morbidity, or MLTC as the NIHR like to call it, is basically many conditions, many long-term conditions within the same individual. And it's now a research priority as outlined, for example, by this Academy of Medical Sciences report in 2018. So there's a number of reasons that it's a research priority, both for individuals, where pretty much across any outcome you can think about, multimorbid patients will have poorer outcomes than people with single conditions. There's also a huge treatment burden, partially because of the research we've done before and because of the focus on single conditions. A lot of the kind of guidelines and stuff that we use to treat patients are based on these single conditions. And when you start putting multiple together, you get problems with drug interactions, just the general number of things the patient needs to think about when managing themselves, for instance. So there's a lot of individual issues. There's also a lot of system issues. So these patients represent the majority of utilization of our healthcare services, health and care services, I should say, as well as the costs, obviously, of these, our payments for the NHS and local authority tax burden for social care, etc. There's also, again, because of how we've kind of evolved our systems through time, there's kind of fragmented approaches to how we treat these patients recently. So they have contacts across the system because they have multiple care needs and health and care needs, like I said, which our systems really aren't currently set up to deal with. So there's a lot of, for instance, policy maneuver towards integrated care to try and kind of smooth some of these transition points, etc. There's also a huge link to inequalities. So these multimorbidities occur earlier for more deprived populations, as well as more frequently. So there's a huge kind of underlying theme. There's obviously a kind of priority for the University of Glasgow moving forward in health inequalities that is kind of running through this work as well. So because it is a priority for research, obviously the funders are getting behind it as well. So we've got big funding from UKRI in general, from the NIHR, like I said, as well as kind of the third sector. So for example, the Richmond group of charities have a task force on multiple conditions. There's also been some previous priority setting work trying to frame what this research might look like. So for example, the James Lind Alliance, which primarily talks to patients and what their priorities are for research, published this multiple conditions in later life, top 10 priorities. So they focused on later life, whereas the absolute burden of multimorbidity is actually earlier in life as well. So that's something to bear in mind. Now, obviously, the James Lind Alliance and the patient perspective is quite applied. They're interested in how their care looks when they go to GP or other services. Whereas a lot of the kind of funding of research we've seen today has been, I guess you could classify as more basic science. So we've been kind of outlining what the problem is currently. So where are the people using services? which conditions co-occur together in our current system, etc. And there's been a lot of money, for example, spent on clustering of diseases. So like I said, this kind of current idea, as well as kind of new methods to get at this, for example, artificial intelligence, which is obviously the big thing these days. So there's potentially a slight misalignment of what patients and our outcomes are interested in and what the kind of research we've done, at least to date, the majority. So that's not to say that all of the research has been basic science. Obviously, there's been quite a few interventions attempting to get at kind of improving outcomes for these patients. For example, this review in 2021 found, I think, 16 RCTs looking at interventions in primary and community settings. But really, the results of these have been mixed, to give it a generous approach, and there's a lot of remaining uncertainties. So there's not been yet any definitive, I'd say, interventions published to date. So in this work, we've taken this kind of primary care perspective as our baseline, our kind of foundation. So an academic primary care perspective has been defined as the scholarship of community-based clinical practice. So it involves both clinicians that do academia as well as just researchers like myself. The reason for this primary care approach is obviously the majority of primary care contacts are with these patients. It's obviously the big, in most systems, generalist clinical setting in, pretty much all setting. And it's the bedrock, really, of any integrated care program. I mean, for example, in the UK, obviously, it's a kind of gatekeeper role for sending people elsewhere as well. So, and the WHO recognizes this in pretty much every system as well. So our aim here was to basically identify and prioritize a primary care researcher agenda for multimorbidity. So very briefly on the methods, we took a kind of three-phase approach to doing this, where we kind of imagine it as a big funnel, where we kind of, so the first stage, we just had an open-ended survey question, where we just wanted people to generate ideas of what are the big unanswered questions in this area. In the second phase, we took it to a workshop with 18 participants, and we kind of talked through what had come out of these open-ended survey questions, tried to generate a shorter list of more clearly worded questions. And then the final stage, we took it into Delphi. So we again, and tried to internationalize at this stage our sample a bit. So we went to academic primary care researchers and said, these are the questions we have. How would you rate them on a Likert scale of 1 to 9? And then we, typical Delphi kind of style two stage approach, where we defined consensus as over 70% reaching a score of 7 to 9. So onto the results. Just from the workshop, very briefly, I won't touch on it much here, but the real kind of theme differentiator from kind of single condition research was this complexity involved in these patients, obviously, and their interactions with the system. So the heterogeneity of patients that people are seeing don't potentially fit with the kind of guideline-based approach that we've come from to date. In terms of the Delphi questions, so we had 10 kind of research priorities that reached consensus, and we categorized these into two types. So the first was on, we called models of care. You can see here, the first one was on the kind of primary care workforce and how that might look going forward, and a lot of these kind of different skill mix and stuff like that, it comes up in that as well. The second was around the current primary care model and how kind of which bits we need to keep from that, which bits we might tweak and lose. So this kind of more short term, how do we improve services quickly? Third was around kind of new care models completely, and particularly around these outcomes of making it more patient-centered and, as I said, that kind of burden of treatment question as well. Fourth was really around prevention. There's a lot of talk about how we can potentially save the kind of deterioration that we see in these patients in the long term by getting ahead of the game if we can. The fifth was around this integration approach, so interaction with the wider health and social care system and how that might look for these patients. And the sixth was how do we basically implement some of this more successful stuff once we have it. So yeah, barriers and potentially facilitators to doing that. And then the second set of questions, which is really quite different, as you might expect from the kind of priorities that patients and others have previously outlined, are these ones around methods and data. So we had, for example, the seventh question on resource allocation models, particularly. So this was around, yeah, basically health economics stuff around how we resource properly primary care to deliver some of this stuff. The eighth was around quality of the data we gather and how that might improve. The ninth was around getting away from kind of RCTs as our only approach maybe for doing this. So RCTs obviously kind of strip out some of the complexity that we might be interested in many ways. And there was a big kind of emphasis on using more administrative data, more quasi experiments, and potentially complexity methods going forward, system science methods, for example. And then the 10th was around outcomes. So there was kind of debate on how relevant some of the outcomes we currently use as our final indicators are for these patients. And maybe we should be looking for some of this kind of quality of life and potentially different ways of measuring for individuals' priorities, etc. So just to give a few limitations, it's obviously relatively small sample size that we're looking at in this study. It's very UK-centric in many ways. So I think even the Delphi, where we tried to internationalize, we still had around 75% of the participants were from the UK. Obviously, these aren't necessarily all of the important questions on the topic going forward. And there was it's under revise and resubmit at the moment in the journal. And one of the reviewers, for instance, had an interesting comment about maybe creativity is actually what's needed in this space going forward. And I think we'd agree with that as well. Yeah, to conclude then, I think priorities differ quite substantially from what has been funded and published a lot to date in this area. We hope it offers funders and researchers a potential future grant calls and research plans going forward. And yeah, we really think that addressing complexity element is going to be a challenge for funders and for researchers. And we may need to think about some of the methods we use in that. And just final slide on that to kind of frame it in terms of obviously school. I do think this area fits very nicely across all these topics, and some of the priority questions I'm sure will ring a bell for any of the themes you're involved in. So solutions, obviously this fits most, I guess, in because it's about applied and interventions, new interventions, what they may look like. But there's also determinants, like I said, these patients are the ones that are receiving the poorest health outcomes to date. The health inequality stream runs throughout, as I said. And obviously the data element, for the research questions are around, that we came out with are around research and data. So yeah, there's obviously overlaps there. So yeah, hope to get involved in some of this research with somebody going forward. Thank you very much.
Johnny, important work. Any questions from anyone? And any questions online?
No questions online, no.
We've got one question here from the audience, and I'll try and repeat it because I think the audience online struggle to hear the question. So,
thanks, Johnny. Really interesting, and obviously there's a lot of multi-morbidity work going on, particularly around general practice primary care and other places. And were patients involved in the Delphi study? And if not, do you think involving them would give you a different set of questions?
sorry, Johnny. So just to repeat that for online, in case you didn't hear, were patients involved in the Delphi study, and would that have given a different set of questions?
Yeah, so for this one, we purposely didn't involve patients because of that James Lind Alliance approach that had recently been done, basically. What we did was compare our kind of final set with the ones that were generated from that. And there was some overlap. So they were interested in, obviously, the applied kind of new pathways, some of the outcome stuff they were interested in. So these kind of quality of life outcomes, burden of treatment outcomes, for instance. Obviously, the real bit that differentiates what the researchers were interested in is the kind of methods aspects, the data aspects, particularly. But yeah, there were some overlaps. Again, the later life kind of emphasis of the James Lind Alliance might have kind of differentiated this as well, because of a lot of those were focused on, yeah, particularly geriatric case assessments and things like that. So very specific to later life falls and stuff like that. Whereas ours, I guess, were more seen from a kind of what primary care perspective, what they treat day to day. So it's a bit more, yeah, broader, I guess.
What's the level of seniority and experience of these? When do you have any plans to include non-specialists, but past non-specialists, or allied healthcare professionals?
Yeah, so the question is regarding the qualifications and experience and of the participants, and are you going to add in sort of lay people, I guess, or allied healthcare professional?
Yeah, so we didn't really discriminate in terms of the seniority. So yeah, to begin with, we recruited through what's called the NIHR SPCR, School for Primary Care Research, which funds 9 centres in England to do primary care research. So we asked each of them to begin with to nominate people that are basically involved in multimorbidity research. So that was our primary criteria, was, are you actually doing this research in some way and know the topic? We then kind of supplemented that through Irish and other home nations, so Scottish and other people that we knew were involved in this area. So, I mean, there is a range of experience in the people, for example, that attended the workshop in actually Delphi. And again, we didn't, so some of them were GPs by background. A lot of them weren't actually. So yeah, some were from allied health professionals. Again, we didn't make this a specific criteria for going out to recruit people, but there were a range of backgrounds, basically.
Thank you very much. And thank you very much to all 3 of our speakers. That was really interesting. I hope online audience could hear all of that and hear the questions. We'll try and get that arranged for next time. So, but please, if you would like to, and I would urge you to consider contributing to these seminars, and if you'd like to, please do get in touch. Hear from you as well. Thank you.